Good day or good evening, depending on where you are in the world. My name is Joanne Robinson. I'm from the US, and I chair the ICS Nursing Committee's Subcommittee on Education and Practice. On behalf of the Nursing Committee, I am delighted to welcome you to the nursing workshop on promoting bladder and pelvic health in populations with continence vulnerability. We have 4 wonderful speakers on deck, and it is now my pleasure to turn the program over to Dr. Angie Rantell from the UK, our workshop chair.
Thank you very much, Joanne. And again, welcome to delegates watching from all over the world, and welcome to ICS 2020 online. As Joanne said, we're going to be talking today about promoting bladder and pelvic health in populations with continence vulnerability. And it's a real pleasure to be joined by 3 speakers from the US today who are going to be looking at different populations. So for the start of the session today, I'm going to talk about promoting pelvic floor health and sexual function in menopausal women. I'm then going to introduce Dr. Saiki, who's going to talk about nurse-led community outreach programs to promote continence in marginalized populations. And then Dr. Krabbenhoft is going to talk about a self-management protocol for long-term urinary catheter users in community settings. And then we have Dr. Amy Hull talking about the non-surgical management of stress urinary incontinence in postpartum women. We do have time at the end set for questions, so I'd like to remind you to please use the live chat to ask the faculty questions, and please make sure you reference who your question is for in your written comment. So I'm going to go straight into the first presentation, looking at promoting pelvic floor health and sexual function in postmenopausal women. And these are my disclosures. So when we think about menopause, menopause is a term that just means that it's been 12 consecutive months without menstruation. And for most women, this occurs naturally at around the age of 51. What you often hear women report is perimenopausal symptoms, and this commonly occurs in their 40s, and it's when they experience symptoms such as more irregular periods, weight gain, mood changes, changes to skin, hair. And then when we talk about premenopause, that's your average woman who is in from the time of their menstrual cycle starting up to the perimenopause, where they have no noticeable changes in their hormones. And when we think about what menopausal symptoms are, they're generally grouped into 2 different sections. The vasomotor symptoms, which is where come the hot flushes, the sweats, and the genitourinary syndrome symptoms, which is what we're going to be focusing on today. And the reason this is important is because our population is aging. And we know that as women are living longer, women are now spending about 40% of their life in a postmenopausal state. And again, as the older population is increasing, we know that over the next few years, the numbers of women in a postmenopausal state is going to significantly increase. So if we think at the moment, if this is using the cutoff of 65, there are 266 million women in the world over 65. If we think about from 51, potentially even bigger numbers, and it's meant to increase to 1.3 billion older people by 2040. And although we think, oh, you know, menopausal symptoms aren't going to be happening to everyone, when we look at the prevalent studies, actually, half the time we're asking women the wrong questions. And when they're asked the right questions, 80% of them have suffered from some form of vulval vaginal atrophy at some point. And actually, when you look at symptoms, 100% of women have reported some vaginal dryness, nearly 80% some pain or discomfort during sex. Half of them have had burning or itching in the vulva, in the vagina, and a third of them have reported some dysuria. But often patients don't volunteer the symptoms, either because they don't realise that it's relevant to other problems, they're too embarrassed, or actually more worryingly, 1 in 5 people think that healthcare professionals just aren't interested in this, so aren't volunteering anything. So the question is why are these symptoms so linked to our urogenital tract and the lower urinary tract symptoms that we may often be seeing women for incontinence clinics? And it's a hormone issue. When we think there are several different hormones that affect the urogenital tract, and most commonly they're estrogens, progestogens, androgens, selective estrogen reuptake modulators, and antidiuretic hormones. And actually, estrogen and progestogen receptors have been found in the vagina, the urethra, the bladder, and all through the pelvic floor musculature. And the rationale behind this actually takes us back to our embryology. So this is the lower urinary tract of a 9-week fetus. And what you can see here is that actually you have one urogenital sinus. By the time this develops to a 12-week fetus, the one urogenital sinus has split and become the urethra and bladder and the vagina and the uterus. So it comes from the same embryological origin, hence why the hormones affect them both the same. And when we look at hormonal changes within the body, what we're seeing is that during our fertility years, our estrogen's nice as high and coming through the perimenopause. And then when you get to the time of the menopause, you get significant fluctuations in your estrogen levels alongside a significant deterioration in your progestogen. And it's the fluctuations in estrogen that often cause most of the symptoms. So when we look at symptoms, we actually have some appropriate terminology, which is genitourinary syndrome of menopause. And this is defined as a collection of signs and symptoms associated in a decrease in estrogen and other sex steroids involving changes to the labia majora, minora, clitoris, vestibule, introitus, vagina, urethra, and bladder. And there are many different signs and symptoms that are associated, such as genital dryness, decreased lubrication during sex, pain during sex, decreased arousal, irritation and burning of the vulva, urinary frequency and urgency. And common signs are that decreased elasticity or loss of moisture in the vagina, more fragile tissues, urethral eversion, and recurrent urinary tract infections. So the question is, how do we assess these women? And the reality is the most difficult thing often is starting the conversation. And as a healthcare professional, one of the ways that we just promote health from there is to actually broach the topic with women and ask the questions. We need to do a holistic assessment. So when we're assessing for lower urinary tract symptoms, we also need to assess for bowel symptoms, menopausal symptoms, and sexual function issues. We need to understand the most bothersome symptom for women and help with that. And then we need to tailor the care to the individual patient. So when we think about our initial assessment, we already know from the International Consultation on Incontinence Initial Management of Urinary Incontinence in Women that the assessment of estrogen status and treatment as appropriate is already well documented and recommended as part of our initial assessment. But when we come to actually asking about more detail, we need to think about more detailed clinical symptoms. So we need to ask about vaginal dryness, itching, an increase in vaginal discharge that may be associated with an atrophic vaginitis. We're going to look at lower urinary tract symptoms and bowel symptoms. And we're going to ask them, A, if they're sexually active, B, if they are sexually active, if they have any problems with it, any pain or dysfunction. And if they're not sexually active, why they're not sexually active? Because it may be they're not sexually active because of these problems. We're going to ask the age at which they went through the menopause and if they've had any symptoms. We also need to consider the use of HRT, other comorbidities, and reviewing their medications, including herbal treatments that they may be taking for menopausal symptoms. And then we're going to look at what a holistic involves for these women. In reality, a holistic approach in many nursing circumstances is about providing patients with a safe space in which we can listen to them, that they can talk about their problems, that we can then give them advice and support and guidance, and then we can do some health promotion within that. So what advice and health promotion can we provide for this group of women? Well, in the most simplest forms, we're going to talk about how to manage symptoms. So we're going to talk about the use of vaginal moisturizers or vaginal lubricants and help them understand the difference, because most people will be buying these over the counter and often aren't sure. So we're going to advise them that vaginal moisturizers are designed to deliver that hydration, to moisturize a dry or damaged vaginal tissues, and they're to be used on a daily basis to improve comfort in the vagina. They're meant to give immediate and long-lasting protection, and actually some of the brands can last up to 3 days between applications. On the other side of this, lubricants are actually just designed to be used during sexual activity. And the aim is to alleviate discomfort, ease penetration, and increase pleasure. And although they're far more slipperier than the moisturizers, they're very short-lived and dry a lot more quickly. We're also going to talk about skincare in the same way with patients with incontinence. You're going to talk about this. We know that women post-menopause have far more fragile tissues in the vagina. And so we're going to talk about vulval skincare. And actually, the British Association of Dermatologists have created a really useful guide for patients on care of vulval skin, which can be downloaded for the internet. And what they recommend is that women should avoid soaps and bubble baths and shower gels and perfumes and feminine deodorants and antiseptics, that we should be washing the vulva gently, either using hands or a soft flannel, and that the area should be patted dry with a soft towel. Often women, particularly if they have leakage, wash more often, and we actually need to tell them that we don't want them to wash it too often because that aggravates it. So once a day is far better. And they should be applying an emollient moisturizer cream or lotion regularly. And in the same way that women moisturize their faces or their hands every day, we should be encouraging them to moisturize their vulva daily. One of the things that people very often shy away from is the topic of sex, but we need to be very much to keep that holistic health, speak to women about sex in the postmenopausal years, because for many women it has significant problems. But the evidence is that by staying sexually active in later life, not only is it good for your physical health, but also your psychological health. But it really is true what they say, that if you don't use it, you lose it, because sexual intercourse can actually help to keep the vaginal tissues healthy. We know that vaginal penetration keeps the vaginal tissue soft, stretchy, which prevents the tissues from shrinking and atrophying, but it also stimulates natural moisture and lubrication. But we also need to recognise in this group of patients that either they may not have partners, or their partners may have other health conditions that prevent them from allowing active penetration potentially. So we need to speak to them about alternatives, so ways of which they can remain sexually intimate, but without having specific intercourse or penetration. So talking to them about extended caressing, mutual masturbation, massage, that may be what they are able to do and will still keep them happy and from a relationship point of view, but not then causing problems if they aren't able to have the penetration. When we look at the North American Menopause Society, they have other different options that they recommend for promoting pelvic floor health. So we should be promoting exercises. So for most women with continence problems, we would be speaking about pelvic floor muscle exercises. But it's not just about improving the strength. In many cases, particularly if they've had significant issues with pain, it's about looking at relaxation of the pelvic floor and helping them to manage and improve the discomfort with penetration. And the pelvic floor exercises can also be used with massage and trigger point techniques to try and help with this relaxation and comfort. And again, people may use aids such as vaginal dilators to try and stretch and enlarge the vagina. And it's not just vaginal dilators that we can advise. There's a whole range of devices. Dilators, people use when they want to medicalize it more. Some people like to use things such as the TheraWand. Some people like to suggest sex toys. Some people might want to talk about mindfulness. We can also recommend other devices, such as what you see in the bottom right-hand corner of the screen, which is called an ONA, which tries to prevent collision dyspareunia and can help to improve pain during intercourse. So we need to have an understanding of what's out there and help educate our patients with regards to these. When it comes to hormone replacement therapy, this is often an area that elicits fear in a lot of people talking about it. And in reality, to cover HRT in 15 minutes just isn't possible. So I'm not even going to consider systemic hormone replacement therapy here, because in reality, actually, for urogenital symptoms, systemic HRT isn't what's recommended. What we're really talking about is local estrogens. So the topical or the local estrogens are applied directly into the vagina, and they have a direct action on the urogenital cells, not only to help innovate or re-innovate the vagina, which then helps to try and reduce some of the reliefs, but because we're putting it directly where we want it, you get far greater improvement with a far smaller amount of systemic absorption. When we talk about the vaginal estrogens, there are many out there on the market. The most common ones that I use personally in my own practice are Ovestin cream, which is used daily for 3 weeks and 3 times a week after that, or Vagifem, which is a vaginal tablet that's generally used for daily for 2 weeks, followed by alternate days. And the concern is always going to be that there is systemic absorption and there are increased risks. But actually, from all the studies that have been done, the amount of hormone that gets absorbed systemically by using these regularly is the equivalent of taking 1 systemic HRT tablet per year. So we know that it's very low dose and it is therefore safe. And in the UK, our NICE guidelines tell us that we should actually be offering low-dose vaginal estrogens to women with urogenital atrophy, and they should continue on it as long as treatment is needed. Because it is recognised that although it can take 6 months to even a year to reverse the changes of atrophy, once you stop the treatment, the symptoms will come back. So it is often a case that women will need to be on a long-term basis. There is always a concern when you talk about HRT in women that have had breast cancer or have a familial history of breast cancer. And actually looking at the guidelines by the American Congress of Obstetricians and Gynecologists, although yes, non-hormonal therapy should be first line, such as the vaginal moisturizers and lubricants that we've spoken about and the physiotherapy, estrogens can be reserved for those who are unresponsive. And we would generally recommend speaking with the oncologist involved in their care just to make sure that they are happy. But the evidence shows that low-dose vaginal estrogens don't result in sustained estrogen levels exceeding that of a normal menopausal range. And there are no data to suggest that by using the vaginal estrogens, it increases your risk of recurrence in women that are either undergoing treatment for breast cancer or have a previous history of breast cancer. So ultimately, genitourinary syndrome of the menopause is very common in postmenopausal women. The prevalence increases with age, and for us in practice, that as the years develop, we are going to be seeing more and more women with postmenopausal problems. It can significantly affect pelvic floor function, lower urinary tract symptoms, and cause a significant impact on a patient's physical and psychological quality of life. And they both have significant impact upon a woman's sexual function. As a healthcare professional, often the most difficult thing is actually starting the conversation. And really that is if I want you to take anything home from it, it's please ask, speak to people, ask about menopausal symptoms, ask about sexual function. Because if we don't ask the questions, like you saw at the very beginning, people don't volunteer them because often they don't think it's relevant, or they're too embarrassed, or, as I said, more worryingly, it's because they think you don't care. But actually, we really should. And ultimately, for any treatment that we give, predominantly it cycles around advice, education, guidance, support. It's health promotion, it's education, it's helping develop expert patients to self-manage. But we really need to tailor it to the patient's need, depending on what impact the GSM is having on their life and whether it's manifesting in lower urinary tract symptoms, sexual function symptoms, or a combination of all of those. So thank you very much for that. If you have any questions, I will happily answer them at the end. And what I'm going to do now is I am going to hand over to Dr. Laurie Saiki, who's going to give us our next presentation. So thank you very much.
Just have to take 1 minute to pull it up. All right. Hello, everyone. My name is Lori Saiki, and I am a certified continence care nurse with 15 years of nursing experience in women's health and 15 years of teaching experience. I currently teach at New Mexico State University and am engaged in community-based research in southern New Mexico, which is a predominantly rural and Hispanic region along the US-Mexico border. It is an honor to be with you today to share my community-based outreach efforts to promote urinary continence in this marginalized population. I'm grateful for the research funding that I've received from 2 grants, the first from the New Mexico Office of Border Health, and the second from the Mountain West Clinical Translational Infrastructure Network, which provided NIH funding through a health disparities pilot grant. I couldn't do this work without the support of my co-PI, Martha Morales, and patient conscientious work of Francis Martinez in translating materials. Both are pictured here, and I'm also grateful for my partnership with the good people of the Southern New Mexico Promotora Committee and their leadership team, Angie Sanchez and B. Martinez. The goal of our research is to reduce urinary incontinence symptom severity and improve quality of life for rural Hispanic adults. As you all know, urinary incontinence is a prevalent condition. Most people, however, don't report their symptoms until they've been living with incontinence for many years. By the time they approach the topic with their healthcare provider, their quality of life has been significantly affected. Why don't they tell us earlier? When self-management strategies are more effective in either reducing the severity of incontinence episodes or eliminating their incontinence altogether. Well, they don't tell us because they are embarrassed. They worry about being stigmatized and seen as infantile, old, and feeble, and falling apart. They worry that they will be made fun of or left out of social activities. They don't tell us because incontinence is not considered life-threatening, and so they suffer without guidance or support from continence care nurses. Urinary incontinence is a significant health condition with a high cost burden, not just in terms of what happens to the body or the expenses of treatment for incontinence, but also significant economic and psychosocial costs. For example, people change their clothing style to hide pads or leaking episodes. They quit jobs that do not allow easy access to bathrooms, and they start isolating themselves from social activities and interpersonal relationships. We all know how stressful social isolation has been during the COVID pandemic. Imagine if we thought this would be our life forever. For these reasons, I believe that it is important to reach people before their incontinence is severe and before they ask for help. Who better to reach out to their community than the community health workers or promotoras de salud? Promotoras are known and trusted in their rural, small communities. They engage in outreach health education as clinic liaisons and often volunteer on their own time to run groups in their homes or at community centers. By training local promotoras and maintaining a partnership to provide ongoing support and feedback, I hoped to improve accessibility to evidence-based incontinence self-management strategies in a way that would be accepted by primarily rural, primarily Hispanic community living adults. The community-based participatory method helps me make sure that the continence education is useful to the community. First, we had to assess whether or not the promotora community was interested in incontinence. And yes, they were. Then we had to assess what they knew about incontinence, and there was a lot of misunderstanding and misinformation. For example, they didn't know the difference between stress and urgency incontinence.
They thought incontinence was mostly caused by a fallen uterus after childbirth. They had no idea how to do pelvic floor exercises. They had no information on managing urinary symptoms, and they had a lot of questions. We entered into an ongoing process of education, getting feedback, answering questions, and correcting misinformation. Our collaboration led to the development of a set of 4 educational modules that were approved by the Department of Health for continuing education credit for the community health worker. Because I wanted to be able to reach the broader promotora community, in addition to those who are able to attend monthly meetings, the modules were developed using an online learning management platform called Canvas. Through Canvas, I could track their participation in the modules. I could see what content they looked at and how much time they spent working in the system. Canvas is also smartphone compatible with interactive capabilities, and this was important in our region where broadband is expensive. In the Train the Trainer pilot to evaluate the use patterns and feasibility of our work, we covered content found missing in our previous needs assessment and content that was requested during the pre-training development sessions. We had 4 modules estimated at 1.5 hours each that had short animated videos, demonstration videos with male and female models of pelvic organs, and printable PDFs of PowerPoints with transcripts. The participants had a post-test, an evaluation survey, and a follow-up phone interview. The first module covered the major types of incontinence, symptom profile, contributing factors, and the promotors had requested information on incontinence and diabetes, so that information was threaded throughout the modules. Reminders to refer people to healthcare providers were also threaded throughout the modules as well. And then to dispel some of the myths of incontinence as a sign of feebleness, we covered brain bladder communication issues post-stroke or with dementia. In Module 2, we covered self-management strategies for stress incontinence. We also covered self-management of urgency incontinence in the 3rd and 4th modules because most of the promotores did not understand urgency incontinence. We covered promoting a healthy bladder, typical urination patterns, how to calm the urge to urinate in order to avoid leaking before they could reach the toilet. We covered how to establish bladder retraining by voiding on the clock for progressive increase in time intervals to reduce urgency episodes. The next phase of our work will be to test the effectiveness of this nurse-promotor partnership in improving urinary incontinence symptoms in the community. And here we're facing some challenges. First of all of our community health promotion outreach efforts have shifted due to the pandemic. But even after we can resume our work, we still have some ongoing issues to consider in terms of research design and demonstrating cause and effect. The community health workers are very engaged, and they have shared their module content with each other, with their friends, with family members. And it will be my next challenge to compare outcomes using this partnership model of outreach education to standard practice. And I'm not even sure I'm going to be able to figure out random assignment to group. So lessons I have learned in this process is to take time to build relationships and also to pay attention to the relationships between the stakeholders that need to be built in order to navigate to keep moving forward. In the rural communities, there are generational relationships between families, and those relationships run deep. The promotores are very passionate about their role to promote health in their communities and believe in their value, as do I. However, this makes for a challenging research backdrop, and I'm not sure how I will navigate negative results if that happens. Along the way, I always need to bring something to the partnership, give of myself, and not use them as data points. Incontinence is intensely personal and still hidden. I hear many personal stories as I work with the promotores, and my working relationship will only be meaningful if it's based on trust. And that trust is developed over time with an ongoing open communication. Thank you for listening, and I look forward to your questions and feedback at the end of this workshop.
Thank you very much, Laurie, for that really interesting presentation, and congratulations on such a large amount of work, but something so very much needed. And I'm sure we're going to have a lot of questions about this coming up. What I'd like to do now is hand over to Dr. Lisa Krabbenhoft, who's going to give us our next presentation. So thank you very much, Lisa.
Thank you, Angie. All right, let's get this pulled up. There we go. All right, so first of all, I want to thank everybody for coming here today, whether it's morning, afternoon, whatever time of day you're getting to watch this or attending this. Very much appreciate your attendance. My name is Lisa Krabbenhoft, and my background has been a lot of work with individuals with neurologic injuries, primarily in the acute care, acute rehabilitation center setting. So that's what I'm going to present here today. So the topic that I'm going to talk about is self-management for long-term urinary catheter users in the community setting. I have no affiliations or disclosures to do. All right. So learning objectives here for today. At the conclusion of this presentation, my goal is that you will be able to describe components of a standardized self-management intervention for long-term urinary catheter users, transitioning from a post-acute care, so a rehabilitation center, into the community. All right, so before I dive into the self-management approach, I'm going to talk a little bit about the population. So we were able to actually use this intervention in a population in an acute care rehabilitation center here in the Midwest. This population included individuals with neurologic injuries such as spinal cord injuries, multiple sclerosis, as well as individuals with Parkinson's disease and strokes. Now, not all of these individuals with these neurological medical diagnoses will require bladder management or the need for urinary catheterization. But as you can see here by these percents, a large percent or a majority of these individuals will have some sort of bladder management need long-term. So what my focus is here today is on individuals who have to utilize urinary catheterization, either clean intermittent catheterization or indwelling catheters, which is urethral or suprapubic catheters for long-term bladder management. To be considered long-term bladder management, we usually say 30 days or longer. For all of these individuals, urinary catheterization will be their main form for bladder management throughout the rest of their lives. So we hear a lot about self-management, and I guess a lot of times one of the biggest questions that I get asked is, so why do we need self-management strategies? Why do patients need this? Why is it important to me? And I think one of the biggest things that we want to try to tell individuals and to teach individuals is that we're trying to help provide that support to them. We want them to be able to be independent, and we want them to be able to do their daily cares as independently as possible. That means they need to be involved in their daily management. And for this, it would be their daily management related to their bladder function. Now, with bladder management, we know that there's a lot of challenges day to day in the hospital, out in the community. In the hospital settings, we're finding shorter length of stays in the hospital. Individuals don't have enough time maybe to receive that education, to identify resources in the support network. That makes it very challenging. Out in the community, having access to resources and even having access to educators and professionals who are familiar with urinary catheterization can be a challenge. But ultimately, our goal here is to improve the bladder management and then lower our medical utilization and decrease our healthcare costs. So we want to ultimately bring down those complications, have less urinary tract infections, have less need to go to the ER for catheter placement. So that's our focus here. So when we talk about self-management components, those foundational components include social support. For individuals, social support can be family, friends, peers, healthcare providers, anybody who's involved in their daily care and their daily lives. What we want to do is by including these individuals in that transition time, they can help with daily planning and also provide that support to the individual because we've changed their lives. They're going to have a totally different way of life, a totally different way of managing that bladder. So it's very important to include that social support and to identify it early. Next step would be the bladder management education. So this includes catheter care, fluid management, urine output, looking at the color of the urine, the odor of the urine, and then we also want them to be aware of what kind of complications to be watching for, what are those signs and symptoms of those complications. We also have to do education on daily care needs, how often they need to catheterize or how often they need to empty the catheter. This is going to be very individualized. Everybody comes in with a certain amount of knowledge possibly, and so we have to make sure that this education is individualized and meets the patient's needs. It's also important to be aware of how they get education and how they get information. Some individuals may utilize internet resources, and so by providing them with good, safe, accurate information, places to be able to go get that information is important, as well as those individuals who don't have internet access, so having paper format or a book or something like that for them to go back to look at. The next component would be patient activation. Patient activation is defined as purposely engaging in healthy behavior symptoms monitoring and implementing a course of action that can lessen debilitating symptoms. So how do we get patient activated? I think that's probably one question that we all struggle with. And it's not going to be the same for everyone. What works for somebody may not motivate another individual. So being aware of that. And unfortunately, for some individuals, the motivation doesn't happen until a complication occurs. So it might be that first urinary tract infection that actually makes them become activated to help prevent them from having another one. So all of these components then lead into self-monitoring. Self-monitoring is the process of being aware of symptoms or bodily sensations that are enhanced through periodic measurements, recordings, and observations to provide information for improved self-management. The process of self-monitoring actually requires the individual, and if a social support person is involved in their daily care, requires both of them to be actively engaged in their daily care. It also helps to facilitate education, and it helps to promote long-term bladder management and prevention of complications. So this would be a self-monitoring tool that we would ask individuals to include in their daily routine. So as you can see, the two main focuses here are both intake and output. So we're looking at fluid intake throughout the day. This is an example of somebody who had some breakfast in the morning and they had caffeinated coffee, water, and orange juice. Here they would document the types of fluids and then the amount of fluids. Oftentimes, individuals will not be this precise with documentation of their fluids, so they may not write down exactly 12 ounces, 6 ounces. We encourage them to do what makes sense to them. So if it was a cup of coffee, write down 1 cup of coffee. The whole focus with that too is that they're aware of what 1 cup means. So for some individuals, a cup of coffee may be something small. Others, it may be a large grande cup of coffee. So being aware of what they're talking about and how they're documenting these amounts is very important. Over on the right-hand side, you can see urinary output. So for this individual, they are doing self-catheterization, and they catheterize themselves twice in this document. So here we can see they catheterize for 600 cc's of yellow amber, and then later on in the day, 800 cc's for light yellow. The goal here is by having them side by side, individuals are able to make a connection between their fluid intake and their urinary output and how the types of fluids that they're drinking can impact what their urine looks like. On the far right side, there is a column there that says journal. What we are asking individuals to do here is start to look for complications. So being more aware of how they're feeling and what their urine looks like. So you can see here up at the top of this urinary diary, there are examples of journal notes. So did they feel less well? Maybe they started a new medication. Maybe their urine was cloudy for the day. They would mark an X in this column and then proceed then to the journal. So this is an example of an intermittent catheter journal. You can use this as well for an indwelling catheter individual as well. Here they're going to document what they noticed. So at 6:30 in the morning, they had less urine than usual, and then what they thought, what was going on, or what did they do about it. Now, a lot of times individuals will use a urinary journal as a way to document things that are abnormal or out of the usual. But I also encourage individuals to document things that go well for them. So if they have a great day of drinking a lot of water, make sure they write that down, that they did drink how much water and what they noticed with their urine and how they felt. The idea is between looking at both the urinary diary and the catheter journal that they have a resource to go back to when they're out in the community. So when they have changes in their urine, they can go back and take a look at these things. So our outcome, we want to include the patient and the caregiver in their daily care. We can do this by using those two tools. We also want to improve communication between healthcare providers and the patient. We want to assess the patient's ability to self-manage and their readiness for discharge. And ultimately, we want to prevent those complications. So when we go back here and take a look at this intake and output form, a lot of patients identified that they had never really actually had communication with their healthcare providers about what their urine looked like. For many individuals with an indwelling catheter, the nurse or the healthcare provider would come in and just empty the catheter bag and never talk about what their urine looked like. So by using this form, it actually helped facilitate that communication between the two. And individuals were able to start identifying how they felt and how their urine was looking, or how much they drank throughout the day and how that impacted their urine. So all these are important, as well as for the healthcare provider to find where educational support is needed. By looking at this urine, this provides an opportunity for the healthcare provider to talk about the importance of drinking water throughout the day, limiting caffeinated beverages, what worked well, what didn't work well. It's a great resource and can be adapted to individual needs. That's the end of my presentation, and I look forward to questions at the end. Thank you.
Thank you very much, Lisa. I think that very much fits in. There's lots of initiatives around the world that looking at developing expert patients so that they're empowered and educated to identify problems and self-manage. And it's really linking into that sort of international drive with those. So thank you very much. Up next, I would like to very much introduce Amy Hall, who is going to talk to us about the postpartum population, which for me clinically is a group of women that I see an awful lot, and there's not very much out there. So I'm looking forward to hearing more from Amy. Thank you. You're on mute at the moment. There we go.
And then share my screen. There we go. Whoops. Oh, so sorry. Well, it doesn't want to seem to stay put. So I do want to thank everyone for the opportunity to present information on incontinence in the postpartum childbearing population. The previous screen, I do not have any disclosures. I do want to thank the Society of Urologic Nurses and Associates for allowing me to present today. And thank you to the International Continence Society for allowing us to be a part of your workshop. So these are our objectives, and I'm going to move on from there. So stress urinary incontinence is identified by the International Continence Society, as we all know, as any complaint of involuntary loss of urine on effort or physical exertion. And it also includes exercise, sneezing, coughing, laughing. It affects as much as 40% of women aged 40 years and over, and contributing factors include race, increasing age, tobacco use, lifestyle and occupation, as well as obesity and childbirth. So it is a very prevalent problem, and we don't really think about the childbearing population as having a huge issue with incontinence. Again, we sort of consider this as a condition for advancing aged women, but prevalence studies have shown that there is quite a significant spread of incontinence among postpartum and childbearing women, as little as 13% to 55%, with some research suggesting that there's an increased risk of stress incontinence with large babies greater than 4,000 grams, as well as increasing parity. 60% of women there is a 60% risk of stress incontinence for women later in life who also may have experienced stress incontinence during their pregnancies. And we know that surgical correction may not be the most appropriate management option for these women, as often women who are either postpartum or still recovering, of course, or who are also considering future pregnancies. There's limited data on effective treatment, unfortunately, for this population, and there are also barriers for treatment to this population. Again, it's just not as well identified among this population as it is among older women. There are several treatment options, obviously. Observation is an option. A personal program of pelvic floor muscle exercise and lifestyle modification might be palatable to a patient, to a woman. Also targeted or structured program of pelvic floor muscle exercise with a specifically trained physical therapist could be a good option. Use of a continence device or continence or incontinence pessary might be appropriate, as well as surgical correction with various slings, mid-urethral slings, pubovaginal slings, and then different types of bulking agents. So of course, we're specifically going to be talking about non-surgical management for this population. And so my goal now is to give you some information on what is out there. And unfortunately, there is not a lot. Some research has been done on the pregnancy and postpartum population with regard to pelvic floor muscle exercise. And in this work of questionnaire studies, questionnaires dispensed to patients, authors found that women who began an exercise program during pregnancy were less likely to experience stress incontinence postpartum when compared to women who didn't begin their exercise program until after they delivered. They also found that women who practiced pelvic floor exercise were more likely to be older, interestingly, non-smokers, in general exercisers, and more likely to breastfeed and also have larger weight babies. Other research actually looked at randomizing women to a structured, supervised program of exercise and an unsupervised program of exercise. And what these authors saw was that among women who self-reported incontinence, women in the supervised exercise group saw a lower percent of incontinence, 19.2%, compared to women in the unsupervised group who saw about a 32.7% rate of incontinence. And then there's a Cochrane review done in 2009 on pelvic floor exercise among antenatal as well as postpartum or post-pregnancy women. And what these folks found was that there is a huge uncertainty that does still persist on the benefits of pelvic floor exercise beyond 3 months postpartum. There was an uncertainty among the benefits among women who were multiparous. And there was also the understanding that there is greater intensity of program with additional modalities, like, for example, electrical stimulation and biofeedback might appear to be more effective. So more intense programs with structured modalities may be more likely to be more effective. So now we're going to talk a little bit about continence pessaries. And here on the top left corner is a continence pessary. So it's a continence dish without support with knobs, so nothing fancy there. And on your right top corner, a ring with support with knob, as well as a ring without support with knob. And bottom left corner are some other types of incontinence dishes with and without, support. And then on the bottom right, a Marland pessary with support. So how does the continence pessary work? Well, it's a vaginally placed device. Most, of course, are made of silicone. And typically the knob portion or the ridge portion of the pessary is located at the bladder neck to help stabilize the posterior urethra. It can be used alone or in conjunction with other non-surgical modalities, such as behavioral modifications or a structured program of exercise. And the three means of benefit of these devices include a support to the bladder neck, an increase of the urethral length, and then also a compression of the urethra against the pubic bone during those episodes of increased intra-abdominal pressure. And so looking at predictors of success or unsuccess of continence pessary management, again, there's not a lot of information out there on continence pessaries in general, and even less on continence pessaries with regard to a postpartum population. So what information I did find was through some continence pessaries studies looked at among women among or across the lifespan. These are multi-center trials that typically have described an effectiveness or successful fit of anywhere between 89 and 92%. And a higher success rate can be predicted or predicated by younger age of the continence pessary user, a longer vaginal length, and a naivete to prior surgery. Predictors of unsuccessful fit might include prior prolapse surgery, prior specifically surgery involving hysterectomy, as well as severe prolapse. Rates of discontinuation, unfortunately, are relatively high, with 40 to 45% at 6 months discontinuing, and as much as 84% discontinuing their continence pessary at 1 year. Predictors for discontinuation of use might include persistent incontinence, so lack of effectiveness of the device, discomfort, bleeding, and then repetitive expulsions. So another large multi-center trial was the Atlas study, and this was a secondary analysis that the authors completed, again, looking at predictors of successful fit. Of note, they randomized 446 women to 3 arms, that being pessary alone, exercise alone, and pessary and exercise in combo. And what they saw with predictors of success, those predictors that might predict a more successful fit included menopause, higher education, no prior urinary incontinence surgery, and a lower urinary incontinence frequency. And they saw no difference in predictors of success among the 3 randomized groups. And we'll talk more about these, the results of their primary analysis here in just a moment. So pessaries for stress as well as mixed incontinence there's some studies available on that. And these authors particularly looked at a retrospective cohort study. So looked at 239 women who had either stress incontinence alone or a form of stress and urge together, and offered pessaries to those women. 190 were offered the pessary, and of those 190, 106 were successfully fit. What the authors found, though, was that 55 women continued with their device for greater than 6 months. And unfortunately, there was a pretty significant lack of long-term use. They did not see any statistically significant differences among the women who continued with the pessary and women who did not continue with the pessary. So back to the Atlas study, the ambulatory treatments for leakage associated with stress incontinence or stress. This was a randomized controlled trial, as I said earlier, to the 3 groups listed here. And what these authors saw was that each group does provide a level of benefit with the behavioral and pessary group being the most effective at 53%. And again, they saw no statistically significant difference between pessary and behavioral arms. And they saw that combined therapy, in looking at their analysis, this is, again, was an intent to treat analysis. They saw that combined therapy was not superior to single therapy, and they saw that greater improvement compared to pessary alone, but again, not better than behavioral therapy. 50% of women in each group reported 75% reduction of their urinary incontinence episodes at 3 months timeline. And the authors also saw that there was a greater satisfaction in the behavioral group than the pessary group, which was very interesting, at 75% compared to 63%. 12-month data revealed that half of the women in any of the assigned groups felt that they were improved and satisfied. So looking at the cost benefits of non-surgical versus surgical benefits can be helpful when trying to determine what might be an effective treatment for women in this age group. And I thought that this was interesting information. These authors found that when looking at non-surgical treatment, they included expectant management, pelvic floor muscle training combined with electrical stimulation and biofeedback, and then pessary. They lumped those non-surgical treatments into one group, and then also looked specifically at mid-urethral slings as their surgical arm. And with the sort of willingness to pay, or set at $50,000 or US dollars, the authors saw that the pessary was the most cost-effective treatment. However, looking over time at long-term efficacy with a willingness to pay level set at $60,000, they saw that the mid-urethral sling does become more effective. Again, however, in the short-term use, and specifically, I mentioned this information, short-term specific use for our postpartum childbearing population who may be having one pregnancy and then another pregnancy and may not be ready for maybe something more definitive. Certainly a pessary and your behavioral treatments might be effective, and certainly cost-effective managements. So what are our take-home messages for today? Outside of the pessary for prolapse and also for incompetent cervix in pregnancy, there's very little research on continence pessary use during pregnancy, and not a whole lot of information on this device and use of this device in postpartum. There's not a lot of research on pelvic floor muscle exercise and additional modalities for that, including electrical stimulation, biofeedback. Not a lot of information on treatment for that population, for that option. And pessaries, even though there's even less information, could be an effective option for postpartum women and for women who are desiring future pregnancy. Certainly combination therapy, pessary with muscle training and other behavioral modifications may be the most satisfactory, potentially more effective treatment for urinary incontinence among this population, and provide certainly a satisfactory and helpful improvement over time for these women. So I thank you very much for the opportunity to speak today. And at this point, I'm going to unshare my screen and turn it back over to Angie.
Fabulous. Thank you very much, Amy. I think it always amazes me. I see so many patients like yourself postpartum that are having problems. And I think especially younger women now with more access to the internet are trying to find things, wanting far more proactive in their needs at this time than what we used to have. And I think the lack of evidence in that population is something that really needs to be addressed. So thank you very much for that. So what we are going to do now is we are going to have a discussion. So please, for those of you watching out there live, we'd love for you to send us some questions, and you can send questions to any of the speakers coming through. Just please using the live chat function. just please remember to make sure you tell us who the question is directed at. And I'm going to get Laurie, Lisa to unmute themselves as well so they can participate within the discussion. The first question I'm actually going to go to is actually based on hormones. And there was a question that came through to me about any thoughts on phytohormones. So phytohormones are predominantly things called like phytoestrogens, and they are the sort of the natural products. It's the hormones that you get from foods. So most predominantly the ones that we see with phytoestrogens are soybeans, red clover. The reality is again, it's a commercialized herbal remedy, and there is no high quality evidence to support the use of phytoestrogens anywhere in the literature. There are also concerns because although people think that, well, they are natural, well, they are natural to the plant that they came from. They're not that natural, and they're not similar to the endogenous estrogens that women actually have. And actually, a lot of the more bioidentical synthetic estrogens are thought to be safer than some of the ones that come from natural plants and products. The other question is there are concerns over the commercial preparations because they often have mixtures of things and very differences in the doses of what you get in them. So there have been concerns raised around that. So yeah, no good quality evidence, but it's like with everything often over the counter and herbal, people choose to take certain supplements, but there's no clinical evidence to support their use. So while we are waiting for the questions to come through, I am going to throw a question first out to Laurie. So Laurie, obviously this was a huge amount of work that you've done for a population, for a specific sort of cultural population in an area. But obviously many of the things that you've done would potentially be generalizable to other cultures, other areas. What advice can you give others for looking to set this up, and you know what things can work for many different populations?
I started getting involved with the promotoras, the community health workers in the community, by going to general community meetings that were bringing together people from all over the region who are interested in health, particularly health along the border, because that's where I'm living. But going to any of the community centers, recreation centers, they often run health promotion programs. And we're not always sure, like, if the quality of the information being put out. So that's where I started, because people were, an individual woman was interested because she was dealing with incontinence with her mom, is what I found out later. But then she brought me into her office and she was hooked up with the Department of Health. So developing community relationships to get out there to work with people who are actually on the ground to capture, you know, health promotion education to people who don't see their primary care provider or a specialty clinic, right, is to go through the community to find those people who are working in the community. And then the biggest important factor was to keep going back. I couldn't just do a one and done, you know, so I need to be in ongoing relationship. They need to hear what I think about what they know. And sometimes that's to talk about the misinformation.
And one of the other sort of underserved populations with a continence vulnerability are men. Any thoughts on sort of reaching out to them?
Yeah, that's a challenging one because the men were even more embarrassed to talk about it than the women. So I often heard through their wives. I had a couple of wives come and ask me about it. And there are male promotores, or promotors. So they were interested in learning, although they often prefaced it because, their mother was dealing with this or whatever. So that's okay. Doesn't matter how they get the information, as long as they have an avenue path to get accurate information.
Fabulous. And a question for Amy. Looking at the pessaries, what's your opinion on using the pessaries as an assistive training tool for pelvic floor muscle training?
Yeah, that's an interesting question. I don't really know. I have talked with some of the physical therapists in my area who do pelvic floor. Most of them typically have removed the device to do, whether it's e-stim, of course, or any type of biofeedback. But when they're doing something more specific, like some type of simple biofeedback, or just helping a patient tactily to identify her muscles, they still typically do remove the pessary. Anecdotally, I have had one patient tell me that when her pessary is in place, she can sense the contraction a little bit better. And it sort of serves as a form of biofeedback for her. So she can contract around that pessary. Beyond that, as far as an opinion of whether or not it helps, hurts, makes no difference for doing exercise, I unfortunately can't say that I can speak to that, except with what I have had as far as interaction goes with my physical therapist colleagues, and then one specific patient that I list there.
Thank you. Thank you. I would just like to say thank you to Flavia for the comment that she sent through, to make sure I highlight when we were talking about estrogens. I've spoken about the phytoestrogens and the topical estrogens or local estrogens, just to highlight the fact that it is well recognized out there that systemic estrogens may actually worsen urinary symptoms, and there is evidence to support that. So thank you for flagging that up out there. Lisa, you talked about the self-management strategies for patients, and you mentioned about carers and family members. To what extent do you think that they should be involved in the process, and at what stage do you think it's best to get them involved?
Sure. Well, research is still really limited on this piece. Including the caregivers into this is something fairly new in the research. But one of the things that we found is that individuals who actually had an identified caregiver who continued with that same caregiver out in the community actually had better success and less complications. So by including those caregivers in the hospital before they discharge and then carrying it forward, they actually had more support and were able to help prevent more complications or identify those complications much earlier. But we also found that individuals who use more indwelling catheters had more need for that caregiver or that support, as opposed to those that were doing intermittent catheters. So there is a little bit of a difference there between daily care needs and involvement in that caregiver.
And do you have any evidence on the impact that has by helping them with that education and developing that self-management, the impact that has longer term on carer burden?
Yeah. Sure. So yeah, this was an interventional study. So we actually had individuals who actually used the urinary diary and journal, and those that didn't have it. And the individuals that had it actually had less healthcare utilization long-term. So there's definite benefits. And for many of those individuals who had the indwelling catheter, it was the caregiver that would actually fill in the diary because they were probably quadriplegics and didn't have the dexterity to be able to fill it in. So by having those partnerships, help reduce their complications long term.
Okay. And Amy, we've got another question coming for you. First off, Aline wants to say great presentations to everyone. So well done, everyone. But I know you spoke about the Atlas study. Are you aware of any other studies that discuss a combination of pessaries and pelvic floor muscle training as a combined intervention?
There's very little, and as a matter of fact, that is the best information out there that looks at randomization of groups. So there's not a whole lot. I had found a few abstracts here and there in looking, but nothing specific to this particular population, certainly.
And I think one of the things for me were around that population is that we've spoken about the devices, so the vaginal pessaries, but generally these are all prescribed devices that are sized and fitted by a healthcare professional. Do you have much experience or any question or recommendations for patients that are finding over-the-counter devices that they're buying online? Any concerns, anything like that about with those devices?
I'm not sure what devices are available between, overseas and here, but what we have here that women can purchase over the counter includes a device called Impressa, which is made by the Kimberly-Clark company. It essentially looks like a tampon, but it's specifically designed for stress incontinence or urinary incontinence, and patients can get it in 3 sizes, small, medium, and large. I actually have sample kits that I try to keep in the office so that if patients want to try that, I give them a starter kit so that they can figure out what size is most appropriate for them before they go and purchase their Impressa. So we have a lot of that particular product used. There's various Kegel exercisers that women can purchase over the counter with varying cost sort of levels. Some of these Kegel exercisers help women to identify their pelvic floor a little bit better. So again, sort of giving them a little bit of a tactile or simple type of biofeedback. And certainly I have several patients who actually use or utilize the various Kegel apps that you can download and put on your smartphone. And those seem to be pretty effective, at least with helping them to get in more of a consistent daily program that they can adhere to.
And we've also got a question coming through from Daphne looking at, despite the lack of research on pessary usage in pregnant women, do you have any experience or recommendations on using pessaries in women, not just postpartum, but those that are actually pregnant?
The pessaries that I've used for women who are pregnant, there's been a few where I've had to place pessary for women who had prolapse and were pregnant. And so we placed pessaries for those reasons. Most of my experience with pessary use during pregnancy is for incompetent cervix, shortened cervix. And so we will use those to help them. Not a lot of information there either, really. I do have a few, not a lot, but a few pregnant patients who are using a continence pessary, one of whom is currently pregnant, and she's also a runner. And so she still likes to run, and will use it when she goes for a run and then uses it only for that purpose.
I think to add into that, from the bit of experience I have using pessaries in pregnant women, the one thing that I will always say is that it's gonna change constantly through the pregnancy. If you think about the pure physiological changes in the second trimester, you've got the release of relaxin that remodels all the collagen in the vagina and the pelvic floor to allow the birth canal to stretch for that. So you're going to get reshaping and resizing, or the vagina is going to change shape and size during the course, predominantly in the second trimester. So often for patients that have had pessaries during pregnancy, I've had to resize them every 4 or 5 weeks because the vagina will constantly change and what used to fit will no longer be suitable.
And certainly with women who are experiencing prolapse during pregnancy, as the pregnancy progresses and that uterus comes out of the pelvic inlet, things certainly do change, yes.
So I have another question for both Laurie and Lisa on this, because I think it's relevant to both sort of things. A lot of this has been around providing enhanced education, communicating with patients, but obviously there are always going to be challenges with communication, whether that be language or situational. And sometimes it's just patients can make situations or communication challenging at times. How have you managed those communication challenges in both your situations?
Lori, if you want to go first.
Well, I mean, in addition to the typical challenges communicating with people in the community versus people who come in to an office setting, it's a different kind of communication pattern there. But I am also challenged because I don't speak Spanish well enough to communicate. So but the people who I've been working with have been very forgiving about that if they feel like my heart is in the right place. So I think if we're communicating openly and with the intention of having actual, communication as opposed to telling them, I think that's the big key for me.
For myself, the communication was a challenge, and it continues to be a challenge. I think when I look at my spinal cord population, they discharge and they may have a plan of where they're going to be at, and that plan changes within months to 2 months or even throughout the year. And their access to be able to get to resources fluctuates. Maybe they have internet access one week and they lose internet access. So having a way for them to be able to access information is constantly challenging, but also stressing the importance of having that information and then where to get additional resources. So if they lose their papers, how do they get more information, and what providers should they reach out to with those questions, I think is important. But that's also why including that caregiver, that additional piece of information, having that resource, a lot of times our patients don't necessarily hear us. They say they understand, they say they get it, but then they leave that situation and they forget. And having that caregiver involved, that support person to also hear that information, to help reinforce it, to help answer their questions when they get home, helps a lot.
And Laurie, do you think the model of accessing vulnerable populations that you've spoken about today, that you've developed, do you think that would potentially have success in other parts of the world? Do you think it's generalizable to other parts of the world?
Absolutely. I mean, it doesn't matter where you live, your people live in their communities, right? And so that's the power of community-based research and community outreach. On the other hand, it makes for a sloppy research design sometimes. So that's my personal challenge, but I have to overcome that in order to be a nurse.
And Lisa, in the same sense, are you looking, so the design that you've gone for, looking to educate and promote self-management for catheterization or long-term catheter care, are you looking to adapt that for other aspects of self-care, whether it be for the bowel management or bowel irrigation, or for physical therapy or other aspects of sort of continence care?
Definitely. I think bowel and bladder really go hand in hand. We know that one can impact the other. So by including those two pieces is definitely important and something that really should be considered. But definitely that considering that population and what resources they have available here in the Midwest, we have a lot of rural areas. And so access to information is different compared to cities. So having that ability to adapt, and by providing online resources, kind of like how Lori did, helps to reach those rural communities and gives them that resource.
And keeping on that self-management theme to try and look, Amy, for your ladies using the continence pessaries, do you tend to train all of them in self-management of pessaries? Do you? What's your views on that?
I definitely encourage self-management. It's preferred. I tell women I like for them to have control over their pessary, not their pessary have control over them. I recognize that my younger population certainly are more active, tend to be more sexually active, and so self-management is key for them. My elderly population I manage, across the lifespan, it's a little bit trickier. And so while that's not the focus of my particular talk today, I certainly do often include partners to help their spouse or partner to have better control, better management of that pessary. I do have a sizable patient population who cannot manage their pessary. And so those particular patients, I see them very frequently, every 2 to 3 months, to monitor for any complications. But with my younger population, it's typically pretty much a no-brainer. They definitely want to manage that pessary. They want to have that control over that device and utilize it when they need it the most. Again, they tend to be much more active, and so they'll use it when they exercise, and then they want to be able to remove it when they want to remove it.
And linking that into the hormonal side of things. So genitourinary syndrome and menopause that I spoke to you about isn't just for women post-menopause. We also see an element of GSM in women that are breastfeeding, because while they're breastfeeding, they're suppressing their estrogens to be able to produce milk. But you often find that if they're breastfeeding for a prolonged period of time, they then get all the symptoms of GSM. What do you do in that post-population to promote their vaginal and vulval health whilst they're using these devices as well?
Certainly, if they have complaints, I certainly give them information on options between local estrogen that could be an option, or some type of vaginal moisturizer. And many of my patients who are typically breastfeeding, they typically, at least in where I'm at, choose to go with the vaginal moisturizer route and use something like coconut oil. We use a lot of coconut oil. Certainly in my much older population, I use a lot of local estrogen for those reasons. But in that younger population, if they are complaining of symptoms, are symptomatic, we give them the option. Majority of them, interestingly, do go with coconut oil, things like that, that are a little bit more just lubricating.
And thank you. And just a final question from me for Lisa. You spoke at the interventional study that had evidence of improvement in carer burden, but did you do any interventions and look at the differences in patient satisfaction to those that were educated and have had the self-management compared to the overall patient satisfaction of those that didn't have the self-management strategies?
We definitely looked at the benefits and asked them if they saw benefits related to the use of urinary diary. And I think ultimately the biggest benefit was the communication. They had better communication with everyone, the healthcare provider, their support, and anybody involved in their daily care. Yeah.
Fabulous. Thank you. Well, I think that is, we're very much at the end of our time. So I would like to finish up by saying a big thank you to Amy, Lisa and Laurie for fantastic topic, not only fantastic presentations, but great discussions here. And so thank you very much for your time with these. I'd like to thank the ICS Nursing Committee and specifically Jan Robinson for putting together the programme for today and doing all the bits in the background, along with all the team in the ICS office. Please, if you do have more questions, please continue to put them in the live chat function, and then they'll come through to the faculty and they'll be able to respond to you at a later time. and please do go to the program page so you can see what the next live session is. So with that, I'm going to say good night. Thank you to everybody, and we look forward to hopefully seeing you at another time when the world allows. Take care.